when I was at university, I had to go to the medical school. I'm a physician, and dentistry was a specialty of medicine. So I am a physician specialized in general dentistry. When I was taking the specialty, I was working at the university, and I saw so many cases of extraction because of a pulpitis, because of a granuloma, because of a cyst. And then I asked myself, how can it be possible that we cannot keep these teeth in the mouth of patients? So I started to read articles and textbooks, and it happens to me to read the chapters of dental clinics of North America written by Herb Schilder. And I was impressed with the kind of x-ray of the root canal treatment, with the lateral canals, curvature, respect of the anatomy. And so I said, I need to know this guy. This must be a magician. And so I started to take courses, and then I went to Boston to continue to take a continuing education courses in the period from 1978 to 1980. In 1980, I spent 4 months in the clinic with Herb Schilder, working with patients and doing some research at the scanning electron microscope. But to tell you the truth, when I found out that the Schilder's technique, that was famous for being time-consuming and extremely difficult and extremely complicated, I was kind of disappointed, because I realized that it was absolutely, and it is absolutely easy, and the things came by themselves. I thought that Schilder was such a magician to be able to introduce instrument and get a pressure point in lateral canals. I said, wow, how can it be possible? And then I told you, I was kind of disappointed, because I saw that he didn't put instrument in the lateral canal, but just the irrigant, they go by themselves. He didn't put gutta-percha point in the lateral canals, but just the plasticide material, gutta-percha, with the vertical pressure, not lateral for sure. And this material would enter in all the empty spaces, empty because the sodium chloride had already digested all the material inside. And so, since then, coming back from Boston, I decided to limit my practice to endo, non-surgical and surgical. And this is what I'm doing, and I keep doing for the last more than 40 years now. And I'm still happy, and I'm still excited. Maybe the future is bioceramic, still with a one gutta-percha point inside, which will act as a carrier with a thermophile, will act as a piston, as a plugger to push the material everywhere. The bioceramic for sure represent the future because of the biocompatibility, because they are hydrophilic. Okay, the only problem so far, problems are the following. First, as far as I know, maybe I'm wrong, but as far as I know, there are not so many articles and the case report already published in the literature. The only big study made and published is on dogs, not on human beings, and very few articles on human beings. I'm going to do exactly the same that I did many years ago when MTA, the first bioceramic material, came in the market. I've been always opposite, for instance, to direct pulp capping, because at that time we only had calcium hydroxide, and calcium hydroxide is not the best idea for sure to make direct pulp capping. But after reading articles in the peer-reviewed journals and written by people that I know and trust, and I saw the result and the long-term result, then I said, wow, it works. And so I started to do direct pulp capping and following the other indication for the use of MTA. And of course, I'm very happy about this. So open episodes, perforation repair, direct pulp capping, and surgery, I use bioceramic every single time. Regarding the new technique, which is very much on fashion right now, which looks and appears like a panacea, you put just the bioceramic sealer, you put a single cone, you don't have to go crazy with the lateral, vertical. You push it and it goes everywhere. Wait a second. Because first of all, a friend of mine, a very good friend of mine from the University of Turin, he made a study which will probably be published pretty soon, and he demonstrated that around the bioceramic and inside the bioceramic, you still have some voids. It's not a complete three-dimensional obturation. First. Second, the bioceramic material after setting becomes hard as rock. So if you are very precise with your root canal working length and you treat for the entire length the root canal treatment, the root canal system, and you will be successful. Okay, perfect. But if you stay short, okay, and for some reason the case is going to fail and need to be retreated, well, so far retreat some material hard as rock inside the root canal, especially around the curvature, is basically and almost impossible. That's why, people can use the single cone and the bioceramic sealer, but they have to be very precise with the working length, because in case of failure, the only treatment will be surgery, which I like it. Thank you. Okay, so right now, because I don't practice in a university, I work in my private office. I cannot and I don't want to make experiment with new material at the expenses of my patient. I let other people to experiment with the bioceramic sealer and the single cone. I wait for more article to be published, and then probably I will stop using the zinc oxide eugenol curve sealer that I still use today and the vertical compaction. But probably the gutta-percha point inside the bioceramic is still useful to be used exactly like the plastic carrier for the thermofil. Let me tell you that a lot of dishonesty is here around. So sometimes the dentist, they don't even know, they don't even tell the patient there is a broken file, and then don't even tell me there is a broken file inside. Okay, so when sometimes I call the referring dentist on the phone, and then I say what happened a few days ago, and I said, look, I took an X-ray and I noticed that there is a small fragment I said is an M2 rotary file, which I don't like because I know they break quite easily. They are too aggressive and they break. And then I said, what should I tell the patient? You know the answer? He said, just raise your fee. Come on. Some other times, the patient comes together with the dentist who broke the file. So he assists during my treatment, and he's the one who pays the bill. This is correct. But some other times, they don't say anything, and it's quite embarrassing. Sometimes, if the referring dentist is a very good friend of mine, then I don't say anything. I remove the broken file. Maybe I raise the fee just a little because I spend more time on my instrument, but not necessarily I tell the patient that the other dentist broke the file. On the other hand, if the patient comes with a specific request of removing the file, I also inform the patient that it's not the removal of the broken instrument that will solve the problem and will be responsible of the pain for disappearing. The problem is not a piece of metal. The problem is that that piece of metal in the middle of the root, which is blocking my irrigants and my obturating material, which cannot reach the apical part. So if I can bypass the fragment and arrive to the apical portion, leaving the fragment in place, the patient can survive with no pain for 100 years. And instead of having gutta-percha and sealer in the canal, he has gutta-percha, sealer, and a little fragment with no influence on the healing. Of course, if I can show the broken instrument in my hands, they are happy. But if I show them and I document that the two canals are joining together, and this I think is another lecture, what to do in a two canals of the same root, okay? Then the patient understand, and so they are happy even leaving the office with a small fragment in their root canal. Once one student asked me, "Doctor, I don't have the gun for the thermoplastic aperture. What do you suggest?" My suggestion was, buy it. Because you need it. It's not just a gadget. You need it every single day. So if you ask me, I have to choose between microscope and ultrasonic. Well, first of all, there's a huge difference in price, because the microscope, at least in Italy, the minimum is about 15,000 euro more. Ultrasonic unit, maybe 2,000. So the difference is enormous. So I cannot say buy this or buy the other one. You need both. They go together. We cannot use the ultrasonic tips, especially inside the root canal, to remove a broken instrument if you don't have the microscope. I installed the microscope exactly September 1995. Everything with the microscope. I say everything. To be honest with you, the only thing I start with my loops, 2.5 magnification, is the very beginning of my access cavity. And this is because having the handpiece in my hands, the spray of water, the visibility is not ideal. And so I can move my head and move my handpiece and take a look. But as soon as when I make my access cavity, I'm very close, not even at the roof of the pulp chamber, but very close. Then I remove my loops, take the microscope, remove my high-speed handpiece, take the ultrasonic tips, and I continue everything with the microscope and ultrasonic tips, including the cleaning and shaping. Where rubber stop goes next to the cusp, I can be very precise. During the obturation, I'm still using the Schilder's technique with the pluggers, okay? Now the plugger is straight, even though it's in night eye, a little bit flexible, but it is straight. So as long as I work in the straight portion of the canal, not only my instrument can go to the very end of the canal or very close to the very end, but also the light and my view. In other words, I can check my obturation the very last few millimeters from the apex. So why not to use the microscope? Surgery, I cannot imagine doing surgery without the microscope, because well, first of all, doing surgery with the microscope is much easier than non-surgical endo, because non-surgical is made in indirect vision through the mirror. Surgery is made in direct vision. We see better, bigger, more light, so why not? But many times I record most of my surgical cases, if not all of them, and there's one moment where I need the mirror, and this is when I use the micro mirror to see my retrocavity. Then at the end of this procedure, I ask the patient, do you want to see the recording of the surgery? Sometimes they say, oh, no, I don't want to see the blood. Some other times they say, oh, yes. And then I put in their hands the micro mirror, which is 3 millimeters in diameter, which is almost nothing in your hands. But under the microscope, it is this big. Now you see the root apex, you see the retroprep, the retrofill. You have a control which is absolutely impossible to have without magnification. So microscope, ultrasonic is a very, very short, little expenses, but they go together. And the next step will be CBCT. So these two big investment has to be done, as well as the microscope is started years ago and is becoming more and more popular every single day. Now is the time for the CBCT, which is becoming also more and more popular every single day. Much more in the United States, of course, not so fast in Italy, and I don't know in other countries, but in Italy we are very, very behind, because we still don't have postgraduate programs. We still, in many universities, don't teach the way they should be teach and so on. will be very critical and very maybe rude, okay? But behind the philosophy of being short, there is only one reason: avoid all the difficulties. Because all the difficulties are in the last very apical 1 or 2 millimeters. So if someone advocates to stay 1 or 2 millimeters short, it just makes the life easier. But please, in my mouth, don't stay short, go to the very end, okay? The very end of the root canal treatment is the foramen, where the pulp used to enter, and now no blood supply can enter anymore because the pulp tissue is dead, but the canal in the necrotic tooth is full of bacteria down to the foramen. It doesn't matter if around the foramen there is cementum or dentin. You are inside the root, the pulp space, the canal space, with no blood supply, no macrophages, no cells, no nothing that could digest and remove bacteria. We have to take care of that portion. If you stay short, you avoid all the difficulties, the apical curvature, everything is there. I wonder, how can other people be successful and relax and dream and sleep at night being short all the time? Because if something happens to me for my mistake, and because I'm lazy, that I finish one case a little bit shorter, the patient starts complaining I had to retreat my own cases. So I said, no way. So the percentage I have, I would say, is about 20% of my cases are for surgery, and the other are for non-surgical endo. Just to give you an idea, tomorrow I have a surgery in upper first, second premolar, and first molar. The day after, I have another surgery in another quadrant for 2 premolars, one next to the other. Then maybe for the following week, I have no surgery at all. So it depends.